Hi guys, welcome back. The next topic that we're gonna study is peptic ulcer disease, and one of the leading causes of that happens to be Helicobacter pylori. What I've highlighted in this image at the moment is the stain that you are familiar about from pathology that is called as Warthin starry stain. This is a silver stain, and the black spots that you can see bang in the middle is representing H. pylori. Well, this is an extracellular bacteria because in the subsequent part of the discussion, I'm going to talk about an intracellular bacteria hiding inside the macrophages of the gut, that is Tropherma whipple in Whipple's disease. So do remember my statement, Tropherma whipple is intracellular, H. pylori is extracellular, and in spite of being extracellular, it's still going to cause gastritis. So let us study how. If they ask you in the exam what is the leading cause of peptic ulcer disease, you know the answer is H. pylori. So he will write the question as type A, type B, type AB gastritis. The correct answer is type B gastritis. I will be explaining regarding type A gastritis in the subsequent part of the discussion, because nowadays integrated questions are asked so he can mix up the information about H. pylori, especially the microbiological information. You see, you are familiar about the fact that this happens to be a gram-negative cocobacillus. Normally, bacteria either live in cocoid form or they may be present in a bacilli form, but this guy can switch from coco to bacillus and then back and forth. This is a non-sporing bacteria. Well, what is the importance of you studying that it is non-sporing? You see, if it is non-sporing, then if you kill it with antibiotics, it's not going to come back again. So eradication is definitely possible, and therefore we use antibiotics for killing H. pylori that we will be discussing subsequently. A question that I usually find people tending to not answer correctly is the route of spread. So I just put up that question to you guys. This extracellular microaerophilic bacteria, this is having less requirement of oxygen. It can survive in the stomach environment, which will not be obviously rich in oxygen, or will be having, I would say, paucity of oxygen. Well, how does this organism spread? Your correct answer would be the route of spread is fecal, which explains to you the fact that the incidence of peptic ulcer disease is more in developing countries as compared to developed countries, because obviously fecal infection will be commoner in developing countries. Now let us look at what is the trouble that this bacteria is causing. So there would be an enzyme that would be playing an important role here by the name of urease, and it is generating ammonia, and you know that ammonia is alkaline. The alkaline pH that is now being created by this bacteria per se is gonna irritate the G cells. There's gonna be 24/7 stimulation of the G cells, so there's gonna be excessive production of gastrin. And once the G cells are producing more of gastrin, this will contribute to more stimulation of parietal cells. The end result would be a development of hyperchlorhydria. You see, this condition will be having hypergastrinemia as well as hyperchlorhydria. This extra acid is the one that will cause trouble, in a sense that it will flow into the duodenum. You see, stomach still has its own security system. The security system, that is prostaglandins, will try to protect it from the acid, but when it comes to duodenum, the first part of the duodenum will fairly be vulnerable. So you will notice that with H. pylori, though the bacteria is sitting in the stomach, it is causing non-erosive gastritis, it would still contribute to a duodenal ulcer developing, because as the duodenum first part does not have a security system, or there is a limited amount of security system that would be functional. Once this duodenal ulcer develops, patient will start developing epigastric pain, and this epigastric pain will usually reoccur every time the stomach will empty. So most of the time the pain in our duodenal ulcer occurs every 2 hours, and a non-medical patient will think that this is hunger pain. So most patients with duodenal ulcer will keep on snacking, because suppose you had your lunch at 2 p.m. and you get tummy pain at 4, then you will not obviously eat another lunch. The person will then purchase snacks and he'll keep on snacking, and snacks are always loaded with calories and fats. So most patients with duodenal ulcer might even be having a weight gain. I repeat this statement. There would be a hypergastrinemia occurring in this patient with hyperchlorhydria. Subsequently, I'll be teaching you that even with less acid, ulcer can be there. I mean, that looks very surprising. I'll explain to you how is that possible. But even when I will say the statement achlorhydria, achlorhydria also contributes to an ulcer. You see, more acid causes an ulcer that even a non-medico can understand. But how does achlorhydria contribute to ulcer is still to be discussed in the subsequent part of our discussion. At the moment, I just wanted to highlight that the leading cause of peptic ulcer disease is type B gastritis, and now we need to do a workup to identify this organism and then get rid of it. If the question says what is the initial test to be done in this case, or what is the screening test to be done in this case, the answer is going to be given as breathuria test. At this junction, I have seen lot of people answering urease test, and they say that urease test has a 95% sensitivity and breathuria test also has a 95% sensitivity. So why not the answer is urease? Well, the reason why urease is not to be answered as screening is because urease is an invasive test. You will have to do an endoscopy of the patient. When you tell a person, I'm gonna put in a scope down your throat, most people would prefer to run away. They may say, oh, I don't want to get this invasive investigation done. So non-invasive investigations are always to be given preference over the invasive ones, which is why, as I said, breathuria test is going to be the screening test for this condition. And in fact, breathuria test is an answer to a second MCQ. If he says, what test is best to determine eradication of infection of H. pylori, the answer is still breathuria test. Urease test, yes, can be done. In fact, in MCQs, lots of time, he has written the term CLO test. That's just the brand name that you need to be familiar with. I highlight the statement that urease test, which is alternatively called as CLO test, is a relatively invasive test. You will have to take a stomach scraping in this case while performing a upper GI endoscopy in the patient. And when it comes to invasive investigations, patients may not be very well receptive to the same. As such, biopsy is not performed nowadays for diagnosis of Helicobacter pylori. That is only for historical purposes that I have mentioned the slide, which is going to be appearing yellowish brown in color with the organism appearing blackish to brown. Warthin stain happens to be a silver stain and is more of historical importance. Now, how to get rid of this bacteria? I need to prescribe antibiotics. So which antibiotics are the ones which are usually prescribed by physicians is one, a combo of clarithromycin and amoxicillin. You might even give ampicillin, but you would have noticed higher incidence of diarrhea with ampicillin. So most of the physicians are more comfortable giving a combo of clarithromycin with amoxicillin. Well, how long should this antibiotic be given? Then ideal answer is 2 weeks. Along with this, you will obviously give PPI to the patient because there could be a concomitant peptic ulcer disease already developing in the patient. Well, PPI might be given for as long as 4 to 6 weeks because that's the ulcer healing time. But when it comes to antibiotics, you mainly need to remember clarithromycin and amoxicillin to be used. From the MCQ perspective, remember erythromycin has not been shown to have effect against Helicobacter pylori. Before I move forwards, I want to say that sometimes when you will read in the textbook and some of the kits that your medical representatives will be introducing before you, those kits could be having, instead of clarithromycin or amoxicillin, even tetracycline. Lots of time you will read and the medical representatives will introduce you to kits that would be having a combination of tetracycline and metronidazole. That's a different issue, that instead of metronidazole, there might be ornidazole present, because metronidazole again causes a metallic taste in the mouth. So a lot of people make a big face when you write metronidazole. If you have ever consumed metronidazole by yourself also, it causes a bit of abdominal pain also. So most people prefer not to write metronidazole and give ornidazole to the patient. Along with this, obviously, PPI can be used and then bismuth can be given. So you can see I've written 4 things here and I've written 3 things on the top. You can very well understand what am I leading at. I am leading at triple therapy, right? That's going to be 2 antibiotics with the PPI. I'm talking about quadruple therapy, where I have introduced 2 antibiotics with PPI with a surface protective agent. Well, how does bismuth act? So you know that the main mechanism of bismuth would be that it will reduce the acid mucosa contact time. You guys know that bismuth is a surface protective agent. The main mechanism of action of the surface protective agent is reduction of the acid mucosa contact time. It is not that in quadruple therapy you cannot be having clarithromycin or amoxicillin. Yes, you can have it, but I just wanted to introduce 4 antibiotics for management of this condition. That would be clarithromycin, amoxi, tetracycline, metronidazole. But I just want to reiterate, the question in the exam said, which antibiotic has not been shown to be effective against Helicobacter pylori? Your answer is going to be given as erythromycin. Just put a cross to highlight not used. We will now compare this information with that of type A gastritis, where alphabet A will come up again and again. Well, type A gastritis will also be having a hypergastrinemia, but it would be having a achlorhydria. Let us study how there would be achlorhydria in this patient. Well, the etiology of this is gonna be responsible. You see, type A gastritis has an autoimmune etiology, so there's gonna be antibodies against the parietal cells. Now, once you have anti-parietal cell antibodies present, therefore the production of acid will be hampered, but still there will be an ulcer. Guys, please appreciate this fact that even if acid is less, still there would be an ulcer present. When I discuss this, lot of guys say, sir, how is it possible? I mean, we understand more acid causing an ulcer, understandable. Less acid causing an ulcer. Guys, in type A gastritis, the stomach defense mechanisms are weakened. You see, there can be 2 reasons for an ulcer. Either more acid or the defense mechanisms of the stomach are lesser. In this case, in type A gastritis, the normal integrity of the stomach mucosa to handle the acid, though the acid load may be even lesser than normal, is affected, and therefore achlorhydria can still cause a gastric ulcer. Since parietal cells will be producing intrinsic factors, so there's definitely gonna be a B12 deficiency. So he can definitely write the word pernicious anemia, or he can just write the word megaloblastic anemia. Now, per se, do remember the statement that I say next, that type A gastritis is a pre-malignant condition. Why I say so is because ultimately gastric ulcer is developing in this case because the defense mechanism of the stomach is affected, and gastric ulcer, guys, is a pre-malignant condition. So it's an indirect question that I've highlighted. In this condition also, because of feedback mechanism, G cells will still be working over time. So please remember, hypergastrinemia is found in both types of gastritis. But in this case, the acid production will definitely be hit, in contrast to hyperchlorhydria that I was mentioning initially. And in some books, you will also read about a combo of the two, that is type AB gastritis. But overall, it is type B gastritis, which is the leading cause of peptic ulcer disease. I will now compare in tabular format the manifestations of a gastric ulcer versus a duodenal ulcer. One, I want you to remember that gastric ulcer, which is a pre-malignant condition, is related to blood group A, and duodenal ulcer is related to blood group O. So you can just remember a mnemonic by the name of DO and just get over with this fact. Subsequently, I want you to remember that the most common site of gastric ulcer is gonna be definitely the lesser curvature near incisura angularis. If you read the Johnson classification, which is given in surgery, he has categorically highlighted that the most common type of gastric ulcer is type 1 gastric ulcer. Whatever I said and whatever the surgeon is saying is basically the same, whether the surgeon says type 1 gastric ulcer or me saying the commonest site is lesser curvature, just adjacent to incisura angularis. Both of these statements mean the same, and I would request you to read the Johnson classification for the various types of gastric ulcers from the surgical part. Now, when it comes to duodenal ulcer, and if he says what happens to be the commonest site, this would be the first part of the duodenum, which could be written in a MCQ as duodenal cap. Let us now understand how these patients will present. Both patients are definitely gonna be having epigastric pain, but there's gonna be slight difference in the presentation of these patients in the following sense. In gastric ulcer, the pain will start developing within few minutes of intake of food. So if I eat food right now and I'm getting this epigastric pain, I might think that the food was too spicy. So I have removed spices from my food, but still the pain is occurring. So I will think that this food item, think like a non-medical. First I thought spicy food, spices have been eliminated from the food. Now when I'm eating something solid, it is still causing pain. So I thought maybe I'm allergic to some kind of food item. So I stopped eating solid food and I start taking soups and milk, etc. Pain would still be present, but would be lesser as compared to taking a solid, heavy carbohydrate meal. So therefore, mostly patients of gastric ulcer, they try to avoid food because it causes epigastric pain, and therefore they start taking products like milk, curd, soup, which are having less calories. As a result of it, there is a high probability that gastric ulcer patients will start having a weight loss. In contrast, in case of a duodenal ulcer, because the pain will come every 2 hours, because that's the stomach emptying time. Every time the stomach contents, the chyme enters into the duodenum, that's where the acid comes in contact with the base of the ulcer, irritates the nerve endings, and it causes pain. As a result of it, this guy will develop a hunger pain approximately every 2 hours, and the manifestation of or the problem in this patient will be that if he's gonna develop pain every 2 hours, you see, there's a limited amount of food, lunch, dinner cooked in the house, no? If the food is finished, obviously he's not gonna eat another lunch per se. So he's gonna purchase some snacks, and snacks are loaded with fat, they're loaded with calories. So most patients who are having duodenal ulcer, they keep on snacking for most part of the day, and therefore we will be having weight gain developing in these patients. This is not a absolute fact that all patients of gastric ulcer will lose weight, all patients of duodenal ulcer will have a weight gain. But yeah, this is the kind of manifestation that is seen, and because obviously there's a distinct possibility that clinically you may not be able to differentiate between the two presentations. Therefore, we obviously need to rely on sending in a camera and seeing under direct visualization where is the ulcer located. So the investigation choice would definitely be upper G endoscopy, and I'm just writing the word biopsy because if it's gonna be a gastric ulcer, then I definitely have to rule out the possibility of a malignancy. I have already highlighted, I'm saying that again for record's sake, that gastric ulcer happens to be a pre-malignant condition. And towards the end of our discussion, this particular one, I'll try to broach again on the list of pre-malignant conditions all through the GA tract. Now, what is going to be the treatment for this chap? Well, we're going to start this person on proton pump inhibitors, the ulcer healing time is approximately 4 to 6 weeks. Most of the time, along with endoscopy, a doctor might actually be doing a scraping of the stomach mucosa also. So most of the time, urease test will also be performed, especially in Indian settings, because incidence of peptic ulcer disease due to H. pylori is higher in India. As I told you, fecal-oral transmission of H. pylori from one person to another. So urease test will definitely be required, especially in Indian patients, because you need to give antibiotics also. In the treatment part, I've written only the word PPI. I have not written antibiotics at the moment because that depends on the report, and the antibiotics to be given have already been explained to you. If they ask you, or if they mention in a multiple choice question, a patient having a refractory peptic ulcer disease, remember my words, refractory peptic ulcer disease means that you are giving PPI, the ulcer is healing partially or maybe even completely, but the moment you stop the PPI, the ulcer is back again. Whenever you read about refractory peptic ulcer disease, you need to think of a disorder by the name of Zollinger-Ellison, which is discussed in hints. That is always given in a question of Zollinger-Ellison syndrome will be the word secretory diarrhea. And I've given reasons for why do you have secretory diarrhea in Zollinger-Ellison syndrome in the topic of Zollinger-Ellison, in that this word refractory peptic ulcer will definitely help you in identifying the disease process as well. I will now be explaining to you the complications that can be developing in these patients on a comparative mode of a gastric versus a duodenal ulcer. Well, both of them can be having bleeding, both can be having a perforation, so let's just evaluate. When it comes to a gastric ulcer, there's a distinct possibility that the patient will bleed and the source of the bleeding will be the left gastric artery. He can actually ask you, what will you do for the management of this patient after volume resuscitation? You've already put a wide bore cannula, you've done a fluid resuscitation, maybe you have given massive blood transfusion to this guy, but once he's hemodynamically stable, you need to perform a upper J endoscopy, and along with this, perform cauterization of the base of the ulcer so that you can control the bleed. There is also a possibility that there might be a perforation occurring with a gastric ulcer. If unfortunately there is a perforation, though this is less now of frequency, I would say the frequency perforation is lesser now because PPIs are so routinely available as over-the-counter drugs. But in earlier times when PPIs were not so available, we used to read about development of a perforation also. And if this perforation will occur, then you can understand that the fluid that will leak out will escape out of the lesser curvature of the stomach and then enter via the foramen of Winslow and enter into the lesser sac. I want you to remember that lots of time you will read about lesser sac peritonitis, whereas in duodenal ulcer perforation you will read about greater sac peritonitis. The reason is pure anatomy. I said the fluid leaks out, goes through the foramen of Winslow and lies posterior to the stomach per se. Then you might even read the term penetration, though it's less likely nowadays. What is the difference between perforation and penetration? I mean, most guys say, sir, are they not the same? Well, the difference, I can put it like this, that perforation is explosive, sudden, and penetration is a slow process of acid eating away into the posterior wall of the stomach, and posteriorly is present the pancreas. So there's a distinct possibility that this penetration could actually damage the pancreas, causing necrotizing pancreatitis. To remember the fact that gastric ulcer can contribute to a person developing a necrotizing pancreatitis, whole pancreatic tissue has been burnt away by the acid. The incidence of such complications have obviously become lesser due to easy availabilities of PPAs. Then there will be very substantial pyloric stenosis occurring in a patient, contributing to gastric outlet obstruction, and therefore you will also notice this word teapot stomach. So please remember, the term gastric outlet obstruction or pyloric stenosis does not only mean that there would be narrowing at the level of the duodenum when it comes to a duodenal ulcer. Gastric outlet obstruction can also be occurring in a gastric ulcer with respect to the pylorus or the pylorospasm that will develop and the reactive fibrotic changes that will occur, and therefore the term used is teapot stomach. On the right hand side, when it comes to a duodenal ulcer, it can definitely perforate. The incidence of perforation is relatively more common in case of a duodenal ulcer. A anterior duodenal ulcer will have higher chances of perforation than a posterior one. You are familiar about the fact that when it comes to bleeding, then it is a posterior duodenal ulcer that will have a higher incidence because gastroduodenal artery goes behind the duodenum per se. The source of bleeding is always to be remembered for every bleeding occurring from anywhere in the body. And if it's a life-threatening bleed, fluid resuscitation has to be done, and then an upper G endoscopy with a cauterization of the base of the ulcer. For the perforation part, I just want to highlight that if they ask you what is overall the most common cause of peritonitis per se, then the number one cause is what we've just studied. It's going to be a duodenal ulcer that will contribute to a perforation peritonitis. Like you are aware, obstruction is due to adhesions or bands. Similarly, perforation peritonitis is mainly because of a duodenal ulcer, and this time the fluid will accumulate in the greater sac, whereas in gastric ulcer the fluid will accumulate in the lesser sac. I shall now be discussing a couple of image-based questions related to the topic that we have discussed, and here you can very classically see gas under diaphragm in the patient. This manifestation of gas under diaphragm may also be written in some multiple choice questions deliberately as Moustache sign. In fact, I'll just mark the boundaries here of the gas, and therefore you will get a better orientation of why is he using the term Moustache sign per se. I will also ask you a MCQ from cardiology. Where do you read about a reverse Moustache sign? I think you are remembering the fact that reverse Moustache sign was explained to you for a patient who's having acute pulmonary edema. The prominence of the pulmonary veins is responsible for what I've just written on the board. I want to emphasize this again. Moustache sign is what you read with perforation peritonitis, that is gas under diaphragm. In contrast, reverse Moustache sign is what you encounter in cases of acute pulmonary edema due to acute congestive heart failure. The next image that I would like to bring to your notice would be the one where you can definitely see a silhouette of air just adjacent to the heart of the patient. This silhouette of air that is adjacent to the heart is seen in pneumomediastinum. Now, because of this air present in pneumomediastinum, because they love to ask you x-rays, at least I can assure you the fact in whichever exam you're sitting for, whether it's gonna be a PG entrance exam or a USMLE exam, at least one x-ray of perforation peritonitis or pneumomediastinum is always asked. In pneumomediastinum, the radiological finding that he wants to highlight is presence of air around the heart of the patient, and the technical term that is used is continuous diaphragm sign. In fact, lots of time they would definitely like to mention regarding a patient suffering from Boerhaave syndrome. In Boerhaave syndrome, they can be through and through rupture of the esophagus, so air can come in the mediastinum, and therefore pneumomediastinum can definitely be asked. In fact, if you look at the image that I have shown or zoomed in at the moment, you will notice that the actual problem in this patient is with respect to the muscles of the anterior chest wall. You can notice some air present in the chest wall. This guy is actually having a presence of subcutaneous emphysema. Probably he suffered from some kind of chest trauma, after which he has developed this subcutaneous emphysema, and along with this, there's a possibility of him having chest pain. So if you correlate the findings of especially subcutaneous emphysema with abdominal pain, which has occurred after especially a bout of vomiting, then there's a possibility that the question could be asked to you for the topic of Boerhaave syndrome also. In the next image, I have highlighted a very classical coffee bean sign. The one where I put the purple arrow is coffee bean sign that is seen with sigmoid volvulus. The second finding is also sigmoid volvulus, where you can notice a bird beak appearance. You can see, you read about a bird beak appearance with respect to a barium swallow, but in this case I have showed a bird beak appearance with respect to barium enema, and that's always a feature that you encounter with sigmoid volvulus. The objective was just to sensitize you to the fact that lots of time in GI tract there might be overlap between medicine and surgery, and most of the questions will definitely begin by saying abdominal pain or chest pain in a patient, but then the radiological images which are present will definitely help you pick it up. I wanna re-emphasize the fact that in the respiratory system, I have talked about mainly pneumothorax, which is always asked in the exam. Right now, I have highlighted an X-ray of pneumoperitoneum where an exploratory laparotomy should be done. Pneumothorax, pneumoperitoneum, and pneumomediastinum are three X-rays that you can never afford to miss. I mean, if you are missing out, let me say, a pneumomediastinum, because it may be a little difficult for you to pick up, I still understand. But when it comes to pneumothorax, which is gonna be jet black lungs, and other features that I've discussed in the respiratory section, and then gas below the diaphragm, I mean, it's inexcusable. So please be very thorough with the current images that I mentioned. And lots of time in the images, you might be looking for pathology in the lung parenchyma, whereas the problem might be in the chest wall of the individual. Like here I've highlighted subcutaneous emphysema, which is what you traditionally read with Boerhaave syndrome. In fact, I can give a case-based discussion here also so that you can be more sensitized to what I have said. I'm describing a 60-year-old male who has come to me with complaints of left iliac fossa pain. Along with this, he's also having obstipation. I'm not saying constipation, I'm saying obstipation. Meaning of the word obstipation is that he cannot even pass flatus. So initially I thought that this guy is having constipation, that is why he is having this abdominal pain, but this was fairly excruciating, so I decided to run a X-ray on this guy. Now the moment I ran an X-ray, and if the examiner is kind enough on me, he will just straight away mention regarding the finding a large bowel obstruction / coffee bean sign. You can very well understand that the question would be of sigmoid volvulus. So majority of questions would either start with epigastric pain or would start with left iliac fossa pain, because right iliac fossa pain is no big deal. Everybody knows you can pick up appendicitis, you can pick up PID, you can pick up mucus diverticulum. So lots of questions on left iliac fossa pain have also been asked in the exam, which is why I have decided to just ask a question like this here. Though the diagnosis is in your face, I've already shown you the image, but I just need to mention it for the completion. While I'm writing this, question for you guys is that sigmoid volvulus, does it rotate clockwise or does it rotate anti-clockwise? Cecal volvulus, cecal volvulus, remember from C alphabet, rotates clockwise. This is gonna be an anti-clockwise rotation. I have basically used this opportunity to mention another case before you of a person presenting with acute abdomen over and above of that of peptic ulcer disease, which is relatively an easy topic and nobody messes up on that. I mean, PUD per se, I would say, is not the actual reason that we are having this lecture. I mean, PUD is so simple that I could have skipped it. It is just that I wanted to incorporate some additional aspects also which are important. I have discussed an important cause of large bowel obstruction. You see, small bowel obstruction mainly would be adhesions and bands, but when it comes to large bowel obstruction, apart from colorectal cancer, even sigmoid volvulus has to be kept in mind. For management of this patient, I will initially be passing in a flatus tube that will ease off the discomfort of the patient. In any surgical case, fluid resuscitation is definitely to be done. And once both these things have been done, then we'll definitely send this patient over for a colonoscopic detorsion. You will notice that in the subsequent part of the app, I have spoken about even a stomach volvulus where maybe a opening of the patient or exploratory laparotomy would be required. But when it comes to a sigmoid volvulus, you don't need to straight away open up the patient. It is colonic detorsion that would be required. An alternative question which can be asked on this topic can actually be modulated. I am describing a 60-year-old guy who's a hardcore non-vegetarian. Like he's an American patient, he eats beef every day and hardly any vegetables. He has been suffering from chronic constipation from all his life. Like he says that he has been to various doctors, nobody has been able to cure his constipation. Today when he came to me, he was having very severe left iliac fossa pain. He was literally doubling up in the bed. And he also told me that he was having fresh blood in the stool, that is hematochezia. You can notice that in sigmoid volvulus, I never spoke about any blood in the stool. But the moment you read about chronic constipation, you read about hematochezia and left iliac fossa pain, the diagnosis will be given as one of the leading causes of lower GI bleeding. One of the important and the most important cause for lower GI bleeding is diverticulitis. And even if he says what is the investigation to be done for diverticulitis, it would be a CT abdomen. Please do not answer a barium enema. You see, barium enema is done for diverticulosis. Diverticulosis will be present before a colitis can occur in a patient. These are two important questions or cases that have been asked in the exam which are having a surgical overlap. But since I was talking generally about acute abdomen and a couple of images that are asked, so I thought that it would be an opportune movement to introduce these topics. I would definitely like you to read about both of these from surgery also, so that you are very thorough and do not miss out on these cases. I will next be explaining to you regarding the various pre-malignant lesions that can be encountered in the gut. So we'll go from top to bottom and we'll discuss the various pre-malignant conditions. While I'm writing the pre-malignant conditions of the gut, question to you guys is, a person is eating गुटखा, तंबाकू जो खाते हैं, right? गुटखा खाते हैं, तंबाकू खाते हैं, तो tobacco chewing से या गुटखा से या betel nut से what lesion in the oral cavity can develop which can be pre-malignant, and definitely oral cancer will occur in the patient in future. You see, gutka or betel nut per se can contribute to development of oral submucosal fibrosis. Do remember my statement. Oral submucosal fibrosis happens to be a pre-malignant condition which can contribute to increased incidence of cancer in future. Do not answer leukoplakia or erythroplakia. Yes, they are also pre-malignant conditions, but they can occur even with respect to dentures, for example. Leukoplakia is white in color, erythroplakia is red in color. Leukoplakia is relatively more common as compared to erythroplakia. But then another entry in the MCQ can be syphilitic glossitis. Yes, do remember, syphilitic glossitis is also a pre-malignant condition, and in the exam he also included oral lichen planus. In contrast, when it comes to oral lichen planus, in some books it is written it is not a pre-malignant condition, in some it is written it is a pre-malignant condition. I just want to resolve that controversy that yes, it is pre-malignant, but the chances are very less. Oral lichen planus may get converted into a malignancy. So if the question is highlighting which is least likely, unlikely, then the answer is again oral lichen planus. But if it is multiple correct options, then you will select it as a pre-malignant lesion. After the oral cavity, I will next describe the pre-malignant lesions that are seen in the esophagus of an individual. Well, standard is achalasia cardia, or I can say Barrett's esophagus, that everybody can answer. So I'll start with over and above this that is asked in the exam, that is tylosis palmaris. When you read this term, it tells you the fact that in the palms of the patient there is hyperkeratosis. See, palms have squamous epithelium. Esophagus also can be having a squamous cell carcinoma developing. So one of the clinical findings that is seen in tylosis palmaris is hyperkeratosis that develops in the palms and the soles. And as I explained to you, that squamous epithelium can definitely be formed in the esophagus, and therefore the end result would be a squamous cell cancer, which is one of the leading cancers of the esophagus. Then is the standard terms like achalasia cardia, which will be having an increase in the tone of the lower esophageal sphincter. Then is Barrett's esophagus, which is due to gastroesophageal reflux disease. And then would be Plummer-Vinson syndrome. Well, when it comes to Plummer-Vinson syndrome, which is formerly called as Patterson-Kelly syndrome, there are three features. One is called as esophageal web. This esophageal web in multiple choice questions is written as post-cricoid dysphagia. That is just to signify the anatomical location of this web. Along with this, there can be iron deficiency anemia. Along with this, there can be coileonychia. So these are three features which are actually described in the triad for Plummer-Vinson syndrome. I also want to bring up a controversy here that in pathology they might say glossitis is a component of Plummer-Vinson syndrome, but at least most of the gastro books and Harrison does not mention about glossitis component. So yeah, glossitis can be present, but I've not put any tick mark in front of it to highlight the fact that if they ask you to select the triad that is seen, then your primary answer would be given as esophageal web, iron deficiency anemia, and coileonychia. Please do not mix up this information with coilocytes. Question to you guys, pathology guys, what is coilocyte? Coilocytes are read with respect to human papilloma virus. Human papilloma virus infected cervical cells. You see, this lady was having multiple sexual partners. She got infected with human papilloma virus, the standard one 1618 that you study, responsible for cervical cancer. So human papilloma virus infected cervical cells or cervix cells are called as coilocytes, whereas coileonychia would basically mean spoon-shaped concavity in the nails. Leukoonychia is a feature where white nails are found in patients of liver disease, whereas coileonychia is a spoon-shaped concavity, grossly opposite of clubbing, where you will be getting a convexity. Next, I will compile a list of pre-malignant conditions that are seen with respect to the stomach. One is gonna be gastric ulcer. The precursor of that is type A gastritis, could also be written. And the third one is Menetrius disease. Now that's definitely an interesting disorder for which I would like to give my inputs from the medicine domain. One, you need to remember that the main cell that will be proliferating here is foveolar cell of the stomach. Parietal cells, on the other hand, are rather lesser. So as a result of this, even this condition will be having achlorhydria. Because of this achlorhydria component and the stomach defense mechanism, which is relatively lesser, these patients can be having a development of gastric ulcer. And since gastric ulcer is a pre-malignant condition, so that is why Menetrius per se has been included in this list. The second feature is from pathology. The stomach rugosities in this condition will become really big. In fact, the rugosities of the stomach might become so big that they might actually look like gyri and sulci of the brain. So therefore, the term that is used lots of time in MCQs would be cerebelliform appearance. Mark my words there. Cerebelliform appearance of stomach mucosa. Cerebelliform appearance of stomach mucosa basically means that the stomach mucosa, when you look at it on an endoscope, the folds are so big that they are so folded, right, that they look like Gyrian sulci in the brain. In fact, this was a standard statement that one of my students told me in one of the previous year's papers, that he actually read this statement of endoscopic finding and he could make a diagnosis of Menetrius disease. For the treatment of this pre-malignant condition, he says do not answer gastrectomy, because though the surgeon will love to talk about various types of gastrectomy because they want to teach you surgical procedures, but in Harrison it is mentioned that for management of this condition, we should be using a monoclonal antibody initially, that is cetuximab. The list of monoclonal antibodies is dramatically increasing, guys. I know that will add up to your load, but I would suggest you to remember at least a few, that I am trying to be very selective in what you actually need to be remembering, and cetuximab is definitely one of them. I will now be teaching you regarding pre-malignant condition that could be related to the small intestine. Well, all of you remember that Crohn's disease can occur both in small as well as large intestine. So Crohn's will be included actually in the pre-malignant condition of both the small and the large bowel. The next condition that I want you to remember is called as Cronkite Canada syndrome. Yes, Canada the country, Justin Trudeau the Prime Minister of that country. So Cronkite Canada syndrome. Well, the problem in this case would be presence of sporadic hamartomatous polyps. You also read about hamartomatous polyps with respect to another condition, right, where there's a mucosal melanosis also present, right? Peutz-Jeghers syndrome. I know you are very thorough with Peutz-Jeghers syndrome. That is why I decided to talk here about Cronkite Canada, which is having sporadic, and any one of these polyps can turn malignant. I will now be mentioning regarding pre-malignant conditions related to the large intestine, where the first one on the agenda would be familial adenomatous polyposis. You see, inflammatory bowel disease is anyway a pre-malignant condition, you know, but they love to ask about FAP, which will be related to APC gene localized to the chromosome number 5. Now, the problems in this condition will mainly stem from the fact that as much as more than 100 polyps could be present in the entire length of colon, and any one of them, because surface area is more, could actually turn malignant. So in these patients, we go in for a prophylactic colectomy. You see, I'm not saying prophylactic polypectomy. I'm talking prophylactic colectomy in these patients because of a higher incidence of adenocarcinoma of the colon. This is a list of various pre-malignant conditions with respect to small intestine, large intestine, then the stomach. Then I spoke about esophagus, and then I spoke about the oral cavity. And for oral cavity, I want to highlight once again, oral lichen planus is plus minus, right? Depending on the circumstances in the question, you need to adjust your answer. I will now mention about a similar kind of a condition like I mentioned for oral lichen planus related to the gut, plus minus for pre-malignant, Peutz-Jeghers syndrome. This is, I think, one of the most well-read topics by people in pathology, so I'll just focus on the salient aspects here. First and the foremost, I'll mention regarding the genetics component. Yeah, it is autosomal dominant. It is related to chromosome number 19, and the genes is what they love to ask, that is STK11 and LMB1 gene. Now, before I describe what's gonna occur in this condition, I can show a couple of images before you that will make you more comfortable with this. they have actually given this image of a polyp, which is very frequently asked in the exam. Well, this is referred as arborizing pattern in the polyp. Arborizing would basically like a plant is growing. So they have actually discussed this in pathology also and even in the integrated session, but I thought that I should mention it before you. And concomitant with that, you can definitely notice mucosal melanosis. This is spots which are found on the lips of this person, but at the same time, I would say that knuckles would not be involved, or I can say that palmar creases will not be involved, because in Addison disease in endocrinology, again I have talked about hyperpigmentation, but that hyperpigmentation can involve the tongue, gingiva, lips, knuckles. It can involve then the palmar and the sole creases. It can involve the flexular areas of the body, whereas in this case the mucosal melanosis is only at two areas, around the lips of the patient and around the anal orifice of the patient. So when you read about mucosal melanosis, arborizing pattern, and the genetics that I've highlighted, you know it is gonna be Peutz-Jeghers syndrome. Now the manifestations that are gonna occur in this patient are mainly gonna be hamartomatous polyps. Well, hamartomatous polyps can be present all through the length of the small intestine, but if they ask you to select one site for Peutz-Jeghers syndrome, it would be jejunum. And listen to my next words towards the end of this discussion very carefully. Guys, the polyps are in the jejunum, but there's a possibility that in this condition, the cancer may not be developing in the jejunum. That's the surprising thing about this disorder, that per se the polyps are usually found in the jejunum and the small intestine, but where will this person develop a cancer? Stomach cancer. You see, previously all the conditions that I was discussing, like for example, if I take a gastric ulcer, it is in the stomach, so cancer is developing in the stomach. If I say FAP, the problem is in the colon, the polyps are in the colon, so cancer is developing in the colon. In this case, the problem is in the jejunum, but the cancer is gonna be developing in the stomach. Shockingly, he might mention increased incidence of ovarian cancer. He might mention cervical cancer. He might mention hepatobiliary cancer. So the point about this particular condition is, listen to this fact again, I'm highlighting very carefully, that the polyp in the cancer will not turn malignant. The polyp in the duodenum may not turn malignant. The cancers might develop at some extra small intestinal sites. So I definitely want to highlight the development of cancers in the ovary, in the cervix, and in the hepatobiliary site as well. I want to finish this by saying it is rarely written that even small intestine might develop cancer in this case. That is why I said pre-malignancy for this condition can be written as plus minus. It may turn malignant at the same site or at a different site. Same is the case for oral lichen planus. So, though all of these are written in the literature for per se pre-malignant lesions, the questions in the exam have been saying which of the following are having least chances of turning pre-malignant. The first answer is oral LP, and then is Peutz-Jeghers syndrome. In Peutz-Jeghers syndrome, as I highlighted, extra intestinal sites incidence is definitely, the incidence of cancer in this extra intestinal sites is definitely increased. And if you just get the genetics and the arborizing pattern, the mucosal melanosis right, you are bang on spot for this particular topic. I basically wanted to highlight regarding the manifestations of certain acute abdomen scenario like perforation peritonitis due to duodenal ulcer, or let me say a development of vomiting of blood related to a duodenal ulcer or a gastric ulcer. I mentioned the sources of bleeding as well. I spoke also in this discussion regarding two abdominal emergencies which were having left iliac fossa pain And lastly, I compiled a list of pre-malignant conditions. So it's more of a, I would say, overview kind of a lecture related to lots of aspects that you are already familiar with, but there are some that if are over and above what you've already studied, just add them to your pathology notes and you are great to actually ready, or I would say set to then attempt multiple choice questions. Brilliant people you are, guys. You will do a great job. You will get great ranks. Just have confidence in yourself and keep hammering, as I always say, the